Alrighty, good evening everyone out there. Thanks for tuning in to ASDA's Advocast. This one we'll be talking about mid-level providers. So we'll just kind of be scrolling through some PowerPoints. We'll be interviewing these two panelists. Questions will be addressed following the presentation. So if you would like to submit any question to the panelists or myself, type it into the box to the right on the bottom of your screen. And if this lasts about 30 minutes, we'll probably wait a little longer, go over time and answer any of your questions. If we do not get to your questions, we will have ASDA staff answer them via email too. So don't hesitate to ask anything, and eventually they will get answered. So tonight's agenda, first we'll review ASDA's stance on mid-level providers. We'll then highlight a brief history of mid-level providers. And then finally we'll interview Dr. Grover and Dr. Peters. And after that, if we have time, I'm sure we will, we'll go into a little Q&A of what you guys might have for us. So I'm Gerard Scannell. I am a third year at LSU School of Dentistry, and I serve as the trustee for District 5. Dr. Jane Grover, she became the director of the Council on Advocacy for Access and Prevention of the American Dental Association in April of 2013. She oversees association activities on topics such as community water fluoridation, dental sealants, school-based dental programs, community health center, access to care, and funding of public health dental programs. And we also have Dr. Deborah Peters of Grand Rapids. She has been an active member and dedicated volunteer with the Michigan Dental Association and organized dentistry for the past 26 years. She's immediate past president of the MDA, bringing a history of outstanding leadership, dependability, and community service. She served as president during the adoption of the dental therapist legislation in Michigan. Dr. Peters joined the MDA Board of Trustees in 2008 as Speaker of the House of Delegates, serving until 2017. She also was a former chair of the MDA Committee on the New Dentist. So thank you, both of you, for taking the time today to talk with us. We appreciate it. So ASDA's current stance on mid-level providers is only a qualified dentist should perform the following functions, including but not limited to diagnosis and treatment planning, prescribing work authorizations, performing surgical and irreversible dental procedures, and prescribing drugs and/or other medications. And a brief history of just what mid-level providers and kind of this issue going on. So they were created in response to barriers to care and the dental health professional shortage area crisis. So barriers to care limit or prevents people from receiving adequate health care. And the most common are financial hardship, geographic location, pressing health needs, and poor oral health literacy. And this is just a stat from as of December 31st of 2018. There are 5,833 dental health professional shortage areas, and more than 10,635 practitioners are needed to meet every HPSA community's needs. So let's get into the bulk of it. First, we're going to ask Dr. Grover, if you can just explain what is a CDHC.
So thank you, Gerard. Community dental health coordinators are not mid-level providers. CDHCs, or community dental health coordinators, are dental versions of community health workers. Now, community health workers have been valued and appreciated in the medical world for a long time, many, many years. In the dental world, we've never had a version of a community health worker until the ADA developed this curriculum. And hygienists and assistants have been participating in the program to acquire these skills and become dental versions of community health workers. Community health workers have shown their value in addressing some of those barriers that you just had on your previous screen. So that is what community dental health coordinators are. They're a dental version of a community health worker.
And to follow that up, what is the process of becoming a community health worker?
So to become a CDHC, or a dental version of a community health worker, there are two pathways. One is to acquire that skill set, that certificate of completion in the CDHC licensed and trademarked ADA curriculum. And there are some professionals, dental professionals, that are doing that as they are becoming dental hygienists and dental assistants. In other words, the first pathway to becoming a CDHC is stacked within an integrated dental hygiene or dental assisting curriculum. The second way to become a CDHC, and this is someone who earns the certificate of completion of the ADA licensed program, is to take it as a continuing education course at a community college. And typically that's where they are around the country, a lot of community colleges.
With your first example being kind of staff, is there a certain amount of years you have to be in that position to become a CDHC? No,
the modules are online for the curriculum, and schools will supplement the modular content with demonstration projects and various discussion activities. But if a hygienist is enrolled, for example, as there are several schools in Illinois, that as people become going through their hygiene program, which can be 2 years, sometimes 3 years, those modules are integrated within their existing curriculum. So that's sort of a simultaneous way of becoming a CDHC while you're earning your hygiene diploma at the same time.
Great. All right, Dr. Peters. So our first question for you, prior to passing mid-level provider legislation, what was the Michigan Dental Association's stance on mid-level providers?
Great. Thank you, Jerry, and I'm happy to be able to participate during ASDA's Advocacy Month. So prior to the mid-level provider legislation passing in our state association's position was that only a dentist can provide certain procedures. The dentist is the head of the dental team. Only a dentist can diagnose, and only a dentist can perform irreversible procedures. We carried it out a little bit further by also making the point that a dental therapy program was an unproven or an inadequate model to be feasible for access to dental care. And we backed it up with several statistics, as well as adoption of this model that was proposed takes time and effort away from working on real solutions, and that we feel are sustainable and won't take years to implement. And we offered many solutions as that came forward in our own state.
Great. And so the mid-level legislation was introduced to Michigan. Can you provide a summary of the bill of that legislation?
Sure, I'd be happy to. So when the bill was presented, it basically proposed a new provider or a dental therapist, and it provided a list of duties that they could perform. And when we evaluated those duties, about 80 to 85% of those duties were current duties already being performed by registered dental hygienists, as well as by registered dental assistants in our state, which is our licensed expanded function dental assistant. It was about 4 to 5 irreversible procedures, such as restoring and prepping teeth and placement of certain restorations and extractions of periodontally involved teeth that we took issue with that was in the bill. The bill also mandated a timeline for this to be instituted in the state of Michigan. The bill did have in the provisions that it had to be a graduate from a CODA approved program. The bill did add a dental therapist to our Board of Dentistry. And it defined what work settings a dental therapist could work in. There was also a definition of how that would affect access to care areas. And one of the final things was there was a mandate in the bill that a study had to be performed within a certain period of time if this was adopted, looking at how the dental therapist licensing affected, one, patient safety, two, cost effectiveness, and lastly, how is it affecting access to dental care in our state? So that's kind of a quick summary. There certainly were many more points to it, but that was kind of a quick summary of the bill that was presented.
What is the timeline for that study?
7 years after adoption of the legislation. So our bill became law and became adopted in March of this year. So timeline is already ticking along on that. And we're still very early in the process. This is, as we'll get to, I'm sure, a little bit later, we're very early in the process.
Great. Yeah, I think we'll get to that in a little bit. Back to Dr. Grover. So how many CDHCs are in the workforce?
Well, to date, we've got a little over 640 graduates from the ADA program. We also have approximately 200 that are currently in training with another program due to be starting in the next 6 months, maybe 2 new programs starting in the next 6 months. So this program is growing exponentially as hygienists and assistants are realizing the value of spending part or all of their time out in the community, and the dentists are realizing new patients from those activities.
Awesome. And have CDHCs been shown to increase access to dental care?
Absolutely. We did a pilot project before rolling this out to the other states. And in the pilot program, which ran almost 5 years, we've got studies from that, case studies from that. But more recently, we are hearing from CDHCs across the country, one in Arizona who has started her own nonprofit with an affiliated dental practice. She is the only dental connection. She is the only one that is providing preventive services under the supervision of her affiliated dentist. We also have stories from Delaware, from Idaho, North Carolina, Nevada. So we're very excited about the results that we're seeing. So many patients are unaware of where care is available, and parents in particular love the opportunity to meet with a CDHC that may be working full or part-time in a pediatrician office. They could be a dental assistant as well. And depending on the State Practice Act, because this model follows the State Practice Act, they can be providing preventive services, if allowed by the State Practice Act, but also connecting families with care. And this is where we're seeing some of the really impressive numbers.
Yeah, that's the most important piece. The non-for-profit, do you know where we can learn more about that, or what the name of it is?
Absolutely, and you may be familiar with Mikkel McRae. She started Tooth Buds in Arizona, a very small town, and I wanted to share with you that in 1 year, in one of her schools, she reduced untreated decay by almost 60%. That's 60, because of her connection with her affiliated dental practice and the numbers that she's able to turn out. We've seen this in Nevada. That group is called Future Smiles, and we would be happy to send you that article, which we hope to publish before the end of the year. We've got a wonderful CDHC, a couple of them in North Carolina, that are working for a large dental practice called Village Family Dental. So if you name a state, we can give you a graduate or two in that area that's doing this wonderful work.
That's incredible. Cool. Okay, so Dr. Peters, once mid-level provider legislation was introduced, how did the association respond?
So once our board determined that fighting the dental therapist was what our membership, wanted, this became our #1 priority. So we had a multi-tiered plan, which included in-district meetings that our member dentists arranged with their legislators, particularly targeting initially the Senate Health Policy Committee. Then we moved on to the Health Policy Committee, and then eventually the full legislature. We have a lobbying team, in Okemos or in Lansing where our capital is, which is our legislative staff for the MDA combined with lobbyists and our action team coordinators. And they met with every legislator at the Capitol. We also updated our interaction with members, purchasing a new system so that we could send out alerts via text. So we kind of came into this decade rather than just emails, and we could quickly text a member, and then they could also interact with their legislator via text or email. That system allowed also to provide coaching for someone who wanted to make a follow-up phone call. So they could quickly connect to a legislator's office with a follow-up phone call. And we also definitely utilize both of our dental schools that we have in our state, utilizing the students through our phone to action, also through letters in district meetings, and they also held their own lobby day coordinated with our lobby team at the MDA. I have to say this was a 4+ year battle within our state. It culminated in my last year, my presidential year, but it was a 4-year battle that we chose to undertake, and use all of our, use a lot of our resources and definitely some of our political capital in fighting this.
I'm sure the fight is ongoing too. How successful has the text alert been too? Because that's something that we've been offering to our members just to keep them abreast of different issues that we're facing.
We noticed a huge increase in effort when we went to the texting versus just the email. Mainly every visit I would go to, part of my presentation would be, now get out your phones, we're all going to register. So it was an easy process. We highlighted it in our journal. We felt like we were doing like what we do for our patients. We were trying to communicate with our members like how they wanted to be communicated. And so you could be standing in the line at the grocery store, get a text and look down, and a few clicks and you were connected with your legislator. So the level of response went up. Each time, if we didn't see what we wanted, we had our leaders follow up within our component level, and we had a much greater response with this effort than we had with any other efforts that we've done both legislatively. So definitely we are a big fan of the phone action.
That's good to hear. So everyone listening, ASDA, we do have our text alerts too. So make sure you sign up for that. Okay, so Dr. Peters, now that the legislation has been adopted, how is the association moving forward with their stance on mid-level providers?
So once it was adopted, we definitely are advocating for successful changes in the law. And we've done that by going through the rules process. So it became law, but then it goes to the Board of Dentistry for the rules process. We've been successfully able to advocate for and make changes in the rules process to make it a better public policy now. So dental therapy, probably our most significant changes that we were able to get in this early process was dental therapists must identify themselves to patients and receive written permission to be treated, so they know they are not being treated by a dentist. And the initial legislation was very vague, and we've made sure that the 500 hours of clinical practice must occur during their formal education process rather than just part of a beginning training under the supervision of a dentist out in practice. We're still in that process, I'll have to say. This is not a done deal. The committee met for 3 months. They were open hearings. We were at all of those. And now it is open for public comments. So it's probably going to be sometime after the new year. And we are very fortunate that we've been able to make some changes in that. There's other provisions that we've also advocated for since this has become adopted and been successful with. And one of those is the number of auxiliaries that a dental therapist may supervise, as well as what's the reasonable distance if a dental therapist is working remotely, if they need to refer on to a dentist. So there's several. Though the legislation was passed, I feel that we've been able to advocate and make it much better public policy by working through the process that we have through our state.
When they're advertising or just letting patients know that they are, is there a way that they have to do it? Do they have to physically advertise that, or just is it more of like a verbal mention that they're a mid-level provider?
Well, what we advocated for is that they had to identify themselves both verbally and when a patient would come in through the clinic or the office, that they would have to sign a form saying that they understood they were being treated by a dental therapist.
Right. Okay. Cool.
I have to say that was very it was strongly opposed by some of the groups that attended those initial hearings, feeling that was challenging. But most of us have been working with other auxiliaries that are licensed in our state, and it's a pretty simple form to put, or pretty simple line to put on your form to make sure that patients are aware of what's being treated or who's treating them.
Yeah, makes sense. Okay, Dr. Grover, so have there been challenges with rolling out the CDHC model?
There have been some challenges. One of the challenges is educating our members and the dental community about what this model really is. It's a new concept in the dental world, case management, again, well accepted in the medical world. But in the dental world, we just expect to hand out a sheet of paper to patients, say, here, call one of these numbers. We expect patients to self-educate, self-motivate, self-appoint, self-navigate, and yet the jargon and the terminology in the dental world is a little complicated. And if people struggle with health literacy, if they are unsure whether they qualify for any sort of Medicaid program, navigators, dental people who are knowledgeable about how the dental world works are very helpful here. The challenge also has been that dental people still understand that there is value in doing a surgical procedure rather than having someone do something that is valuable but not necessarily a surgical procedure. Case management codes are being reimbursed in some states, and so we feel that this is really getting some traction in terms of the third-party payer world. They, as one third-party payer told me, we would rather double down and pay for prevention than keep treating and paying for these $10,000 and $12,000 hospital cases for a disease that could have been prevented. And so the opportunity, even for 2 to 4 hours a week, or even as some savvy dental directors have done at health centers, embed somebody full-time in the peds department or in family medicine. I had one dental director in Virginia tell me, you know, Jane, it's the funniest thing. Since the hygienist went over to peds, we're not only seeing more new patients, but the medical people and the dental people don't hate each other anymore. And I said, well, gosh, that's valuable in itself. And again, you know, we have had some reports, and in fact, one dentist really kept track of how many new patients were coming over from a medical-only site, and it turned out to be about $12,000 to $15,000 per month of new revenue, whereas in the medical site that didn't have a dental navigator, he was seeing about 5 new patients a month. And so I think that's, you know, the proof is in the pudding, and I think that this is just one example that we'll be seeing roll out further. But our challenge is to educate the members and remind them that that value is outside of the dental operatory, not just inside the dental operatory.
And how do you envision the future of CDHCs?
So great question. So we're having more and more interest in this. It's catching on. We actually are seeing more articles in state journals. We think that these kinds of opportunities like AdvoCast, I think that just promotion and just giving it a little more time and spreading the message, educating the leaders in every state. We find it's very effective when we do webinars for particular groups, particular states, and then roll that program out at a community college in that area. So it's catching on with 642 grads and another 200 in the pipeline. I'm hoping by this time next year we should have, gosh, close to or over 1,000 grads.
That's incredible. Yeah, there's strength in numbers for sure. Okay, so Dr. Peters, do you have a strategy? Do you have strategy recommendations for other states facing the same issue for introducing mid-level providers?
Certainly. I think first and most important is you must determine, how important is this issue to your members? And if it's best to fight full force like we did here in Michigan, then, or is it better to advocate for public policy? So determine what's important first, and that, may change. As much as I'd like to say that the legislation that was proposed in this state was proposed for access to care, ours was driven by a different force. Ours was driven by a freedom of choice proposal, so it wasn't driven by by the same in other areas, which made it a challenge, quite frankly, to fight. A few strategies that I think worked well and I would pass along are make sure that the graduates have to come from a CODA approved program. That's key.
Yeah.
It was always one of those questions when I go and I'd ask how many CODA approved programs are there, and people would make guesses, and then when we'd say 0, it would really kind of hammer home the point of making that. Also limit the number of therapists that can treat under the supervision of a dentist. We were able to limit that to 4 in one practice setting, which cuts back on maybe some of the large group models just filling up with just therapists in their offices, thereby reducing the number of perhaps new grads that can go in there. So we were able to limit that. Limit the list of procedures. Limit the number of auxiliaries that a therapist can supervise. Again, help control that setting so it protects the people, protects the patient, and sets it up for success. And definitely, as I said earlier, you want to make sure those clinical hours are part of the school curriculum, not after, while they're on the job. And also key for moving forward, if the state elects to add a therapist to their board of dentistry, make sure the dentist maintain the majority on the state dental board. So in our state, we increased the number of dentists on the state dental board. So kind of some strategies that help fight it. I think the overarching one is determine, what your members want in the area where you're at, and determine, do you fight it full force or do you advocate for public policy?
Yeah, I think really just describing or defining your why first is important. Okay, so lastly, what is, and you kind of alluded to it before, but what is the status of mid-level providers in your state?
Well, we have no mid-level providers. We have no dental therapists in our state, and to our knowledge, there are no schools in Michigan that are starting a program. So at this point, we have none. It's still in the early process, and there's not an ability for anyone to come into our state until the rules are finalized. So someone from another state who's a therapist, it would not be till the rules are finalized. And the way that they are written currently, it would be kind of prohibitive.
Do you have a timeline of maybe when those rules would be set? Is that foreseen right now?
It was defined that it had to be done in a certain period of time. So I believe the open public hearings will happen in February, and then any revision will be made. So probably about March or April of 2020 will be the final process.
Cool. All right. So now we'll open it up to your questions that you've been asking throughout the Advocast. It takes maybe just a few seconds to kind of come through. But while we're waiting, I just want to thank you, Dr. Peters and Dr. Grover, again for taking the time to talk with us. And if you guys don't mind, we'll stick around for a little longer to answer some questions.
Definitely.
Okay, so and let me know if you need me to repeat this question. So our first question, will dental therapists be allowed to open their own office, or do they have to work out of public health office?
In the state of Michigan, as the legislation was written, dental therapists cannot open an independent office. They can only work under a dentist. The practice setting was defined that they also have to see 50% of their patients have to come from an area that's termed an access to care issue. I have to say that that may be a little bit more challenging to define, but that was put in the legislation. So where in our state we have other mid-level providers in the medical field now opening our own practice, that is not currently a model that is adopted in our state.
Okay. So the next question, was this advo-cast recorded? It was. You guys will be able to find it on ASDA.net, and we'll probably be sending out an email just of that recording as well. Next question. Can you share some of the most common arguments you hear against the CDHP model? I think this is for Dr. Grover.
Yes, I'll share two of the most commonly heard arguments. Number one, I was just in a state a couple of weeks ago, and there were some dentists there that were convinced that CDHCs were another type of mid-level provider. And I said no. They're confused, and again, it goes back to an understanding of case management, an understanding of how and why patients need guidance and support and coaching through the dental maze that we have, and to help understand some of the dental terminology that we have, which is very confusing. So another commonly heard argument that I've heard in some states is, oh, well, we do this already. And when you look a little closer, when they look a little closer at the curriculum, and we have some folks that say, well, our state allows public health hygienists. Well, that's great. What does it take to become a public health hygienist in your state? Well, they have to take so many hours of some sort of public health training. So this curriculum has competencies, and everyone who completes this standardized curriculum is assured by their educational institution of having those same competencies. So whether you're trained in North Carolina or Hawaii, who just finished their program, or whether you are trained in Illinois, or whether you're trained in Colorado, the competencies are the same. The modules are standardized. So you don't have an uneven type of education across the board. So those are the two most commonly heard arguments that I hear.
Where can we find more about the curriculum?
So you can go to ada.org, Action for Dental Health. We can give you an overview of the modular content, which includes a really deep dive into motivational interviewing, and also community mapping, which helps CDHCs identify stakeholders. You know, there are many stakeholders in a community that care about oral health for their clients. So ada.org / Action for Dental Health, or you can email me if you'd like further information.
Okay. And we will get your emails out, I'm sure some way to everyone watching and listening. Next question. So as far as costs go, do dental therapists lower the cost of dentistry? That's probably another argument that you both probably often hear.
That was one of the, our strong points. Dental therapy is an unproven model. So in the state of Minnesota, the only state where we have therapists, the state of Minnesota was actually sanctioned for having a lower children's Medicaid through dentistry.
Wow.
So I would say no, it has not been proven to lower the cost, because codes at this time, dental reimbursement or dental codes are reimbursed not based on the provider, they're based on their procedure. If they're performing the same procedure, that is not going to reduce the cost either. our biggest point that we were trying to make to our legislators was that this is an unproven model, and they're taking resources away from other areas that perhaps could reduce cost. We have a program here in the state where we could where if you're part of a public health clinic, you send hygienists out into an area to work, but as a private dentist, I cannot be a part of that. So it restricted our ability to move forward with that expansion of legislation that really could have sent more providers out into the area. And probably most importantly, one of the things that this legislation took away from was our strong advocacy of investing in our student loan payment program, where our dental students will come out and work in underserved areas. And it certainly lessened that message. So a long answer to say no, there's no proof that it reduces the cost, and the reasons why is it's just not built into the model.
Dr. Grover, do you want to weigh in on that, or that pretty much sums it up?
I agree with Dr. Peters. Everything she said is spot on, and I know that there are many states that have developed some very innovative strategies to place dentists into underserved areas. Health centers are a great way, and as students rotate through health centers, they get that public-facing experience outside of the dental school, and then they also learn what it's like. And in fact, as students continue to do that, they're more familiar with the opportunities that health centers offer. But there are some states doing some very innovative things with regard to placing graduates in underserved areas.
Mm. Okay, I think maybe this one might be for Dr. Grover again. Do you know how many schools currently offer CDHC programs?
So great question. We just signed our 19th school. Hooray for LA Mission in California. California, here we come. We have schools that have a national platform, which means they can take students from all 50 states. So we have 19 right now, and we've had an interest, a request actually, for a school in Ecuador, a dental school, for the curriculum, because they don't have currently a community service curriculum. So they're very interested in this, and so we're very excited about that.
That's incredible. Okay, so next question. If dental therapists become the norm, how do you think dental schools will be affected, if at all?
Well, that's a way, of course I would assume dental schools would be affected, but let me start by saying we do not believe dental therapists are going to become the norm. It'd have to take a huge shift in order to make the model work. And the model's been out there for more than 10 years, and it hasn't proven to be financially feasible, nor does it affect access to care. That being said, in our state, when we met with both of our deans, they strongly advocate for, unless the model itself could be proven to be financially sustainable on its own, there just doesn't seem to be interest in moving forward. So, I wish we had a crystal ball, but it would appear that it would have to be way out there, and because therapists can only work under dentists, we're still going to need dentist providers to be providing all that care.
Yeah. Okay, next question. How do you respond when proposed with the argument that dental therapists increase productivity and overall income of the office because they free up the dentist to practice at highest level?
I would also say that my registered dental hygienist and my registered dental assistant also provide that, and they're a valuable member of my dental team. We were advocating for an expansion of our dental assistant duties. Unfortunately, this has delayed that process by 2 years already. We've advocated that we have a strong dental team, and we have many members in it. And certainly a good team is a good team, but there's not that many more procedures that a dental therapist could do that I don't already have auxiliaries that work with me. That being said, as a dentist, there are many things that I'm working along that I am doing as a general dentist that may fall in the realm of a dental therapist, but quickly would go out of that realm. And so from a treatment planning or comprehensive care standpoint, while it may make sense to have a dental therapist go around and pack all my restorations afterwards, I'm not sure if that's going to be fiscally responsible for the, for the practice, or will the fee that the therapists charge have to be so low, or the reimbursement that they would want from the dentist to make it, reasonable or fit with a financial model.
If I could offer a thought on that, and I completely agree with Dr. Peters. I was at a community health center, 14 operatories. We had 5 full-time hygienists. We had 12, 13 dental assistants. We had expanded function dental assistants who were able smoothly to pack and car, place restorations, and do things at a lower dollar level per hour than what I'm reading some therapists make, number one. Number two, the neediest, the folks who are the neediest in terms of dental disease have a staggering amount of dental disease. And it is not just a matter of, hey, I can put in a filling. It's understanding the person on the other end of that, and understanding that the highest level of disease needs the most educated and skilled clinician to handle all of the other factors that go into that.
Awesome. I just have one more question before we wrap up. I'd also like to reiterate, just everyone watching, I know you guys have busy schedules, Dr. Grover, Dr. Peters, you too. So I just really appreciate everyone tuning in. And so as you can see, this is a big issue that everyone's kind of worried about, especially asking if dental therapists would be the norm eventually. But kind of like you said, you don't really foresee that happening. But anyone that is more worried than others, how would you suggest us, one, kind of thinking about the future of dental therapists and mid-level providers, and also, other than tuning into AdvoCast and lobbying, what do you suggest us doing to kind of help what both of you have started and continued?
I would say, as dental students and someone who's going to be out in the profession in just a very short period of time, is keep yourself aware of what trends are happening in dentistry. Be future looking. Look at different models. Be willing to expand beyond the care delivery model that I stepped into 26 years ago. Be open to the suggestions that Dr. Grover spoke of as well. I think dentistry is at a very exciting time. There's a lot of technology out there, with artificial intelligence and different things that are coming on, that you could definitely look and look for different models for dentistry that aren't necessarily going to be threatened by the utilization of a dental therapist. Probably lastly, I want to convey to all the students, don't restrict your movement to coming to Michigan or any other state with dental therapies on our books. Again, I don't feel the model is going to be enough of a threat because it has to be a sustainable model, and it hasn't proven to be sustainable, not just anywhere in the United States, but actually anywhere in the world. It has not proven that it has decreased dental disease anywhere in the world. So I think we'd have a long ways to go, or we'd have to do a 180 to make it more successful. So as students, always be looking ahead, pay attention to forward thinking, or what's on the edge of development for your practice, how you practice, and incorporate those into your training and your future learning.
If I could add a couple thoughts, wherever you practice, be aware of where the safety net clinics are. Support those safety net clinics and have your staff be able to connect patients to those safety net clinics. Be on a first name basis with those dental directors at those clinics. And consider your expanded function dental assistant who can enhance productivity. I don't think enough people realize the value that FDAs have. I think this ASDA generation will really make that impact with that team member. And I would also venture that people like CDHCs who can go upstream and stop this decay and address prevention right in the pediatrician office, either full or part-time. Let's get that age 1 dental visit as a standard of care, and let's head off some of this horrible decay we're seeing.
Hear, hear. Yeah, no, I completely agree. Again, I appreciate you guys making the time. Thank you everyone for tuning in to this Advocast, and just keep doing what you're doing and advocating for the things that matter to us most. And have a good evening.
Thank you. Thank you, ASDA.